Okay, so the session is now being recorded. So we're going to have a look at more acute leukemias today. So we had a look at the chronic leukemias last week, and I think we realised that with chronic leukemias we tend to see the reason they're called chronic is because they're more slower in developing, and also the other reason that they used to be called chronic was because of that they were more mature. These days that term is more correct, so the mature neoplasms, and the reason they're called mature is because we see the mature cells in them. That was a very long way of getting around to that. So last week we saw, particularly with CML, that we tend to see band forms, myelocytes, metamyelocytes, but really nothing less mature than a myelocyte. And this week, having a look at acute myeloid leukemias, you will notice that the cells that we most commonly see are blast cells, and depending on the type of leukemia, of myeloid leukemia, those blast cells can have minimal differentiation, or they can have a little bit more differentiation. So in the very early forms of our AML, the blast cells are even too early to have primary granules or Auer rods in them, whereas the later forms of the blast cells do have the Auer rods. And then of course we have acute promyelocytic leukemia, but we really tend not to get any more mature in the myeloid line along there. The first two case studies we're going to have a look at, because we'll look at them in pairs again. So the first two that we're going to look at are an AML and an ALL again. Now these are the same two cases that you had in the week 8 introduction to leukemias, and I thought that it would be good for us to have another look at them. So I'll just share a couple of screens with you that I've got here before you go along and have a look yourselves. Okay, so these are the two screens that we see. You can see that blood film 4.8 is an ALL, and blood film 4.2.1 is an AML. So the things to really notice here are the clinical history. Can you see my arrow on the screen there? Yes, excellent. Thank you very much. Okay, so the things to look for here are the clinical history, and particularly the age of the patient, because we know that particular leukemias are more common in particular age groups. And the age here with our acute myeloid leukemia. So this woman is 33, and I think the median age for acute myeloid leukemias overall is actually 65, but we can have instances of different leukemias having being more common in younger age groups, and the M2 leukemias tend to be common in people more sort of around the age of 40. But really the thing to keep in mind is that AML is more generally the leukemia of adults, and ALL is more generally the leukemia of children. So of course we do have another spike with our ALLs in much older individuals as well. So when we have a look at our results, of course, we can see that we have a significant anemia. And remember, this is a 3-year-old, so you do need to have a look at your pediatric reference intervals. But even compared to your pediatric reference intervals, this patient is very anemic. and it is a normocytic normochromic anemia. And she also has a thrombocytopenia. So thrombocytopenia is quite common in leukemias, and the red cell count, the white cell count can be quite variable. We can see here that the white cell count is actually normal. And when we look at the AML, again, there's a few numbers here for you to fill in. But again, the person is, I think, is anemic. I'll just check my. Can anybody tell me? Has anybody done these numbers? What's the red cell count and the hemoglobin? Anyone going to tell me? Yep. Thank you. So the red cell count is 2.67. What about the hemoglobin? So 85. Yep. Okay. So usually leukemia does present with anemia, and also, if not a common bleeding tendency, or being a bleeding tendency, and also it may or may not have repeat infections, or not being able to recover from an infection. So, but usually there's anemia there. And again, we can see that we've got a very low platelet count again, and this time the white cell count is increased. So remember that white cell count can be quite variable. With this one, you can see that we do have some polychromasia here. So sometimes you will get polychromasia because remember, this is a space occupying tumour that is pushing out normal hematopoietic tissue, and therefore is sort of pushing out the normal hematopoietic cells as well. And so sometimes you can get a leukoerythroblastic reaction when you see with a leukemia, and so that means that you've got your immature white cells as well as your immature red cells, and this is that crowding out effect on the red cells. So sometimes you do see a polychromasia there, but again, not all the time. So the thing to look for here is the fact that the blast count is so high, and this is not the case with acute leukemias, that the majority of the cells that you see in the peripheral blood are blast cells. It doesn't happen in 100% of cases, but it happens in the majority of cases. And so you can see here that the majority of these cells are blast cells, and this is what tells you that you have an acute leukemia. So it's when you have the blasts, promyelocytes, or they could just be, in this case, they won't be promyelocytes because this is an ALL, but you might have some mature cells here. You can see here that even though this is an ALL, there weren't any lymphocytes actually mature lymphocytes counted in this. There were a couple of neutrophils and a couple of monocytes counted. Or percentage, a couple of percent of them. Whereas with this one, we've got some neutrophils and some lymphocytes as well. But the majority of the cells are blast cells. So this is the reason that we've got these two cases here, is so that you can compare the blasts that are seen. And I've got another screen to share with you. So I'll stop sharing that one. Just need to get my cursor here, and I'll share another screen with you. So what I'm about to show you are images from each of these blood films that Melina has produced for you. And the other thing too that I added just before the start of the prac was new it's not going to do it. Oh, that's annoying. New video of the normal films that also have 100 times views in, that people ask me to organise for you. So that is in the folder today. Okay, that's going to share eventually. Here we go. So this is blood film 4.8. And so this is the ALL, and what I'm keen for you to see here, of course, are the blast cells. So blast cells, remember, are big cells. They are big cells. They're usually very dark. They usually don't have a lot of cytoplasm to them. And lymphoblasts in particular have a much higher nuclear to cytoplasmic ratio than myeloblasts do, although that can depend on the maturity of the myeloblast. So the earlier myeloblasts are going to have less cytoplasm than the later ones, but on the whole, lymphoblasts have a higher nuclear to cytoplasmic ratio. And so what that means is you get lots of nucleus and very little cytoplasm. And so you can see here that there's only a tiny little bit of cytoplasm around the edge of these cells. The majority of it is a nucleus. And these cells have stained up very darkly, but when you have a look at the colour of the red cells themselves have stained up quite darkly too. But you can see a nucleolus in this cell here, and you can sort of see one in this cell, but these two cells you can't really see them, and that could be just because they're a little bit tight in this area of the blood film. So because this white cell count is so low, the white cell count's only 5 point, it's not low, but it is low compared to other leukemia white cell counts of 5.5. It does make it a little bit tricky to find the cells to have a look at them. But the main thing is that they are big cells. They're far larger than normal lymphocytes are. They do look like normal small lymphocytes, but they're much, much larger. Remember, this is a normocytic, normochromic anemia, and so the red cells, even though there is quite a bit of anisocytosis here, they are, on the whole, they are normal sized cells. So you can see the blasts are, a good 2 times larger than the red cells. And when we consider that red cells are meant to be roughly the same size as the nucleus of a small lymphocyte, you can see that these cells on the whole are much larger. So here's another image from that same film. Again, you can see the little bit of cytoplasm, and the cytoplasm that is there is very, very dark. So again, what do you think the main condition that you need to differentiate from acute lymphoblastic leukemia? Just having a look at those cells, what do you think? Where else do we see dark lymphocytes like that, or similar to that? Condition that's, so yeah, that's very broadsy. Well done. What about a condition that is common to teenagers and young adults? Yep, so mononucleosis. So yes, reactive lymphocytosis does cover it, because we do get reactive lymphocytes in other conditions other than mononucleosis or glandular fever. And so yes, you do have to think of whether or not the person has a viral infection, because of course we also know that viral infections can cause a hypoproliferative bone marrow, so they can suppress the bone marrow as well. So you do have to consider viral infections whenever you think you've got an ALL. So going on to blood film 4.2, hopefully you can see that these cells are much, much larger. The blasts are much, much larger. This is an M2 acute myeloid leukemia, so there is some differentiation here. And the other thing to note too is that myeloblasts tend to be far more angular in their shape, whereas lymphoblasts tend to be sort of rounder. myeloblasts are angular and they're more pleomorphic in their look. This film, it has stained lighter. Again, you can tell from the red cells because the red cells aren't anywhere near as dark as they are in this film. So they have, on the whole, myeloblasts tend to stain lighter than lymphoblasts as well. The chromatin is more open and finer. It tends to be more sandy, whereas the chromatin in lymphoblasts tends to be a little bit more grainy and gravelly. The nucleoli are quite easy to see. You can see them here and here and here, and you do get a tendency for multiple nucleoli in myeloblasts as well. It's it's hard to see the two images here, right? And again, when you get a high count, I think I've said this before, when you get an increased white cell count, you do tend to get these groups of cells, of immature cells coming through, and usually the cells are all of the same level of maturity to them. And you can see, you know, these funny little, they call these sort of panhandles on these cells too. That's very common to blast cells. You can see them here as well. And these are much, much larger cells. Okay, so what I'd like you to do, as usual, is to have a look at these two films and see what you can see. They've both got their diffs there to guide you. So basically in each of the films, all of the cells that you're going to see are blasts, and just have a really good look at those blasts and practice. You'll see that I've included all of the information that you need in blood film 4.8. So that gives you a good indication of the sorts of information I'm looking for when you're talking about your cell morphology and number. And remember that in that cell morphology and number box, those three boxes there, along with your interpretation of the FBC results, is the sort of information that I'm looking for that to answer that question in your prac exam. So that question that asks you to describe the blood cell morphology and number, remember, okay? And then your summary and provisional diagnosis information is there also, and so you can see that I've left that blank for you in blood film 4.2.1, so make sure that you practice filling that in. And as you can see, the further differentiating tests, whenever we think we have a leukemia, are really the same. And so that's why you need to know what sort of results each type of leukemia is likely to give you. Now, I don't expect you to be able to differentiate the leukemias on their morphology, but it is more about their CD markers and any recurrent cytogenetic and molecular abnormalities that might give you an indication of what they are. And don't forget, particularly when you get the darker blast cells, that you do need to consider reactive lymphocytosis, as Z quite correctly said, and consider viral studies there as well. Has anybody got any questions about those two cases before I let you go on them? And again, I'll give you half an hour, so that's 15 minutes on each case study. Have a look at the videos, go back and have a look at the normal blood film videos too, and so that you have got something to compare your abnormal films to. So half an hour, so time yourself, 15 minutes per case study, and also answer any questions that are there around the case study, and then we'll come back. So it's 10:19 now, so I'll put people into groups and we'll come back at in half an hour's time, 10:49, so 10:50. So how many? We've got 29 of us here, so 4 6s are 24. So I'll make 7 groups there and allow attendees to switch groups. Good. Got 1, 2, 3, 4, 5, 6, 7. 1, 2,